it is important for us to understand the genetics of male infertility because this gives us an important counseling ability with these patients to tell them what we think is going on genetically and where we think they should proceed in terms of possible treatment. I just wanted to mention briefly, we talked about this before, the trophic hormones and the feedback. And the importance in this setting is that when you look at genetics of infertility, you have three broad categories. You have men who have problems with their pituitary axis. And because of this, they present with very low hormones. This is hypogonadotrophic hypogonadism. Another group are going to present with perfectly normal pituitaries, but testes that don't work. And these men are going to have hypergonadotrophic hypogonadism. They will have sufficient trophic hormones, but the testes don't respond. And lastly, if you have patients who have downstream genetic abnormalities, obstruction caused by genetics, but outside of the testis, then these men are going to be eugonadotrophic. All their hormones are going to be normal. So you can talk about how you treat these patients by looking at whether they have pretesticular, intrinsic testicular, or post-testicular causes of their azoospermia. And then you could then proceed to how do you test these patients and some new directions. This is talking about Coleman syndrome, Prader-Willi syndromes, which are both the hypogonadotrophic hypogonadism. This is hemolytic anemia due to beta thalassemia and sickle cell anemia, again, two types of hypogonadotrophic hypogonadism, but we don't see them very often. This is so this is Klinefelter syndrome. Klinefelter syndrome is an intrinsic problem with the testis. It's hypergonadotrophic hypogonadism. And what you see in this particular individuals is very elevated gonadotropins, low testosterone. It accounts for 2/3 of the chromosomal abnormalities we see in men, or 1 in 500 both. So to put this in perspective, this is a picture of Reliant Stadium in Houston, and it has 70,000 people when it's completely full. If you were to look at all the men as they leave and test them, 140 of these men are going to have Klinefelter's syndrome. So it's kind of a remarkable statistic about how common this is. And then there's other genetic abnormalities due to these increased in the gonosomes, XYY syndrome, in which they can have sperm, and then the 46XX males in which the SRY gene has been pulled over and attached to one of the X chromosomes. We do a lot of work with Y chromosome microdeletions. This has become extremely popular as part of testing in your azoospermic patients, but you should also test it in men who have less than 5 million because C deletions may have sperm. It's a PCR analysis. So how often will you find it? You'll find this in 10 to 15% of azoospermic men and 3 to 10% of oligospermic men. And this is an assay offered by LabCorp, all your major laboratories. You don't have to have a research laboratory to do Y testing. Noonan syndrome and myotonic dystrophy, very unusual causes of male infertility. We're unlikely to see these patients in the clinic. We are going to see mutations in the cystic fibrosis gene because these people are going to come in with downstream post-testicular obstruction. And you do have to have a high degree of suspicion when you see these men who are azoospermia and in whom you have problem palpating the vas. They can have bilateral absence of the vas, unilateral. And interestingly, they can have epididymal obstruction. So make sure if you have unexplained epididymal obstruction, you go ahead and test for CF mutations. The hallmarks of the semen analyses is low volume, less than a cc, acidic, because they don't have their seminal vesicles intact, azoospermia, and lack of fructose. Make sure that these are the individuals you test. Post-testicular can also be due to problems with the sperm tail, which is a consistent problem with all cilia, and this is Young syndrome, where these people have recurrent bronchiectasis and sinusitis. It's due to problems in the dyene arms of the microtubules that form these 9 doublets around the tail of sperm, as well as all cilia. And they get very thick inspissated epididymal secretions. I think I've seen one of these patients in my whole career. Polycystic kidney disease patients you see as adults most commonly, and these cysts can form not only in the kidney but also in the epididymis, causing obstruction. The patients are usually asymptomatic until 3rd or 4th decade. They do and may present with infertility, and this is a form of obstructive azoospermia. So when you ask yourself, what should we test and who should we test? We talked about the Y chromosome already. And remember that with these 3 areas of deletion, A, B, and C deletions, if you find an A and B deletion in your report from your laboratory, these patients will require no more intervention because they will not have sperm. A person with a C deletion has about a 50% chance of having sperm, so they deserve further workup, but not an A and B deletion. Karyotyping, most of your laboratories can also do karyotyping, looking at all the chromosomes. Make sure they're doing high-resolution banding, because if they don't, you can't tell when you get translocations of one part of a chromosome to another. Interestingly, it's going to be found in 10 to 15% of all azoospermic patients, 5% of oligo, and even 1% of men with normal sperm concentration. They can have these translocations. We've talked about Klinefelter syndrome as seen here. These patients will have small, firm testes, sometimes gynecomastia, and usually azoospermia. The one thing to remember about Klinefelter's patients, they can be offered treatment. And the reason is this. Here you see a testis biopsy from a Klinefelter's patient, and the arrows are going to Sertoli cell-only tubules. There's no sperm production in those tubules. But here is a tubule that has focal areas of mature sperm. And so when you do a microscopic testicular extraction in a Klinefelter's patient, contrary to what I said before about looking for tubules, you will see dilated tubules as islands in a field of sclerosis. So this is a really kind of good diagnosis to make because you can then extract these tubules and they will find sperm for the most part in them. The fertilization rate, when you do sperm retrieval, if you find sperm, is about 50%. You still need to have the embryos tested with pre-implantation genetic diagnosis because about 40% of the embryos in larger studies are abnormal. This is an actual case of mine talking about translocation. This is a patient who presented with unexplained poor semen quality. He had a sperm density of 12 million. Only 10% were moving. He mentioned that his sister had had a child that died with multiple birth defects. So we did his karyotyping, and here we've colored the chromosomes differently so you can appreciate that his 6th chromosome had moved to 7, his 7 had moved to 6, part of the 7 had moved to 4, and part of the 4 had moved to 6. So this was a terrible translocation, and obviously this couple could not proceed with any other attempts at IVF because they would not have a healthy embryo. So who should be offered genetic testing? Men with sperm concentrations of less than 5 to 10 million, Y chromosome testing, karyotype testing, men with absent vas deferens on examination, or unexplained ductal obstruction, CFTR testing, or known genetic conditions in which the family has a history of some type of genetic abnormality. You can test often for that specific gene. And lastly, if the patient has clinical features of an undiagnosed genetic condition.